I can see we've still got a few people joining us, and I imagine there may be more to come, but as it's 8:30, which is the advertised start time, I'm going to begin this session. So thank you for joining us. We're going to be talking this morning about soft tissue and musculoskeletal infections. And I think Nicola is going to be recording this session. So if you do show your video, please be aware that your image may be recorded during that time, and also that questions posed on the chat may be recorded and others able to see them later. Okay, so the objectives for today's session are fairly simple. I'm going to cover some important presentations of soft tissue and musculoskeletal infections in children. And I'm going to be highlighting some factors which influence initial management decisions. I'm going to be doing this very much through using some real clinical cases so that you have the scenarios and get you to think about these. And I'm going to be asking you to participate using the polling function in order to give me your sort of own management decisions. There are very few wrong answers. Some questions don't necessarily have a single right answer, or in some cases not even any right answer in them. So please just participate enthusiastically and give your best guess. So we'll go straight in with the first case, which is a 15-year-old girl who is being treated for juvenile arthritis with steroids. And she presents to her local hospital with a fever of 40 degrees, and the main complaint along with that being a very painful, swollen, red right forearm. She has a heart rate of 105 and a respiratory rate of 25 at the time of presentation. And the initial diagnosis made by the admitting team is that she may have a flare of her juvenile arthritis. And so they decide to admit her and give her some analgesia and ask for a rheumatology review. And her initial bloods show a CRP of 250 and a white cell count of 15. But over the course of the day, she becomes increasingly tachycardic and tachypneic. It becomes apparent that she is anuric. She becomes hypotensive and requires inotropes and transfer to a pediatric intensive care unit. And on arrival, she's found to have a tense, swollen right forearm. She undergoes immediate plastic surgery actually on the intensive care unit, with fasciotomies being performed and lavage of pus, which is found between the muscle layers in her forearm and extending into her wrist. And microscopy on the samples taken in theatre show lots of gram-positive cocci in chains. So I'd like to ask you, first of all, what do you think is the diagnosis here? And we're going to use the polling function for this just to get you used to it. So I'm going to, okay. I'm going to launch this poll, and hopefully you see in front of you some options. So I'd like you to vote on what you think is the most likely diagnosis here. Okay, I realize it may not be possible for everyone to vote in the poll based on how you are accessing this webinar. but I'm just going to give it a couple of moments longer in case some of you are discussing this with colleagues. Okay, and I'm going to end the poll in 5, 4, 3, 2, 1. Okay, so these are the results of the polling. So you can see how you voted and your colleagues on the webinar voted. And the diagnosis here is necrotizing fasciitis, actually. And it may be that there is coexisting toxic shock syndrome. But in fact, what I told you on the previous slide, although went over it quite quickly, was that we had gram-positive cocci in chains. And for staphylococci, those would be actually in clusters. Chains are typical of streptococci. So staphylococcal toxic shock syndrome would not be the diagnosis here. And I'm going to tell you a little bit more about necrotizing fasciitis and ecthyma in the coming slides. Let's just see if we move on. Okay, so here is just a little bit of revision of skin and soft tissue infections, how they're classified, the names that we give to them. You can see broadly, you break them down by the layer of the skin and soft tissue structures that are involved. So if they're infecting the epidermis, we have erysipelas, which is a form of very superficial cellulitis, you might say. Impetigo, which I think you'll be very familiar with from working with children, and folliculitis, which you probably also have seen quite frequently. Infections that are down into the deeper dermis include ecthyma, and that's illustrated in the picture over on the right-hand side, where you have these lesions which are quite deep with a necrotic base, and then furunculosis and carbunculosis, which involve different structures of the glands which lie within the dermis. Cellulitis is again a slightly deeper infection and gives you the red appearance that you'll be very familiar with. And remember that because it's that bit deeper, we rarely culture any organisms from cellulitis. And then necrotizing fasciitis is a much deeper infection, again, where the bacteria are in the subcutaneous tissues and passing through the fascial layers and possibly extending to actually involve infection within the muscle when it would be called myonecrosis. And this is a picture here, if you can see my cursor, at the bottom of a very extensive and severe necrotizing fasciitis. So this case was actually a group A streptococcal necrotizing fasciitis. It's a rare condition. It affects approximately 0.25 per 100,000 per year, but it's really important one not to miss because it's very rapidly progressive, highly destructive infection, and it involves, as listed here, the skin, the subcutaneous and deep soft tissue, and sometimes the muscle. The key feature is that it's really spreading along the fascial planes that separate the adjacent muscle groups, and the pathology is a combination of both proteases produced by the bacteria and direct damage caused by them, and also the host inflammatory response, along with clotting that's activated within the small vessels. So you're probably all familiar with one of the most common scenarios in pediatrics in which we see necrotizing fasciitis, and that's as a rare complication of chickenpox, where the chickenpox vesicles act as a portal of entry for group A streptococcus, often after they've been scratched. There may be more to it than that with immune modulator effects of the chickenpox as well. But it doesn't always occur when in the situation of following chickenpox, and sometimes it's a consequence of the bacteria being particularly virulent as well. And group A streptococcus has a whole arsenal of ways in which it fights against the host immune response. to enable it to establish infection once it has entered the body. Not every group A strep produces all of these factors, but these are things that can influence it. So for example, it can produce molecules which actually neutralize the host defense proteins that should be killing the bacteria. It can break down structures called nets that are released from neutrophils to try and trap the bacteria. It can produce pore-forming toxins that actually directly kill phagocytic cells. And probably the most important one in relation to necrotizing fasciitis is this virulence factor. It's a protease called SPICEP produced by group A Streptococcus. And this has the effect of jamming the communication lines that the human immune system uses to bring neutrophils to the site of infection. So what it does is it degrades interleukin-8, which is the main signal for neutrophils to come to a site of infection. And by doing so, it means that neutrophils may not enter where the group A strep are. And in fact, the highest mortality with necrotizing fasciitis is often seen when there are lots of bacteria and paradoxically seeming no neutrophils within the tissue planes that have the bacteria in. So the management of necrotizing fasciitis, early recognition is extremely important, and early surgical intervention should be performed based on clinical suspicion. So it's something where you really need to get the surgeons there immediately to come and have a look. And if there's any question that it could be necrotizing fasciitis, really they need to be exploring it rather than doing imaging studies and so on. Broad spectrum antibiotics are recommended. It's usually due to group A strep, but there are other organisms that can cause it. You must make sure that your antibiotics have anti-staph and anti-strep activity, because the differential might be a staphylococcal infection as well. We use clindamycin because it has an adjunctive effect in suppressing the production of bacterial toxins, all those proteases that I was talking about earlier. And when shock coexists, intravenous immunoglobulin is recommended. And actually, in this case, you could say that this child was on the verge of developing streptococcal toxic shock syndrome as well. All right, so I'm going to move on to the second case and a different topic. This is a 23-month-old girl, and she's been brought to the emergency department by her parents. She had a minor fall in the park yesterday. She has a runny nose, which she's had for about 3 days, and she's been limping this morning and seems reluctant to weight bear on her left leg. She has a temperature of 38.4 degrees C. Her heart rate is 120 beats per minute. Capillary refill less than 2 seconds. She looks fairly well, but she's not very cooperative. Bit hard to examine, and you think that she probably has pain in her hip joint as the cause of not wanting to weight bear on her left leg. So the question for you now is, what are you going to do? And again, we're going to go to the polling here, assuming I can get the polling. Right, brilliant. So I'm going to show you the next poll and ask you, what do you want to do next for this child? So please, can you give me your vote? Okay, so I'm going to close this poll in 5, 4, 3, 2, 1. Okay, so I hope you can see the results there. So I think no one felt that it was appropriate to just give analgesia and review, and most wanted at least one investigation with a combination of bloods and X-ray, bloods and ultrasound, and bloods, X-ray, and ultrasound. And I think any of those options are reasonable, given that you probably would be doing a staged approach to investigation here, and it somewhat depends on what's easily available where you're working. So I'm going to hopefully hide that and move on to the next bit of information about this case. Okay, so this girl actually had an X-ray of her hip and lower limb, which was normal. Bloods were done, but actually after some analgesia, she was looking much better. She seemed to be weight bearing a bit more comfortably on the left leg. And seeing her again, you're thinking, actually, I'd quite like to send this child home. But the blood results come back and we have her CRP. So I'd like you to tell me what level of CRP you think is acceptable to be able to send this child home. So if you can fill in the poll again. Remember that the question is, with a CRP this high, she could go home. I should have said at the start, your voting is totally anonymous. I don't know who's voting for which option, so don't feel shy to give your opinion here. Okay, I'm going to close this poll in 5, 4, 3, 2, 1. And you can see the majority voted for 20, some as high as 80, and 40 was quite popular as well. So we're going to sort of explore the answer to this question over the next few slides. Okay. So in fact, her CRP is 30, and she has a white cell count of 13, and the ultrasound of her hip is performed. So we chose the option of X-ray, bloods, and ultrasound, and she has a moderate effusion seen at the left hip. So given those results, I'm going to ask you again to tell me what you would like to do. Okay, so we've still got a few votes coming in, but I think I will close this in 5, 4, 3, 2, 1. Okay. And you can see the most popular option here was to admit, aspirate the hip, and start IV antibiotics, with a few people opting to admit and observe, and a a few opting to admit and start IV antibiotics. And I think I would say that the preferred option here would very much be the one that was most popular: admit, aspirate the hip, and then start IV antibiotics. Recognizing that this can be quite challenging in a child's this age, and the exact approach may have to be determined by where you work, and you may have to start antibiotics before aspiration if it's very hard to get a hip aspirate performed. I think admitting and observing might be difficult here because the child does have features, as you'll see in a second, that make the risk of septic arthritis relatively high now. Okay. So hip aspirate was done on this child, and it was done prior to antibiotics. We had 1/2 ml of turbid fluid aspirated, which showed white cells, but no organisms were seen on that. She was started on IV ceftriaxone, and actually then a joint washout was performed under general anaesthetic because the surgeons felt that it was likely that it would be a septic arthritis, and methicillin sensitive Staphylococcus aureus grew in joint fluid culture, so the diagnosis was confirmed. Blood cultures were negative. She was treated for 3 weeks in total with antibiotics and made a full recovery. Possibly, or probably, the prompt joint washout contributed to that full recovery without any lasting damage to the joint. So I wanted to just give you a sort of very quick compare and contrast between septic arthritis and transient synovitis, although I realize there is a broader differential, but often this is the main differential that you're considering in a child presenting like this with fever and a limp. Unfortunately, there aren't really many great things in the history or examination to be very certain that will discriminate between the two. So you'll see the peak ages overlap. It's not uncommon to have a history of mild trauma preceding either of them. Transient synovitis is often reported to be associated with a preceding viral upper respiratory tract infection, but we know those are very common in children anyway, and that history certainly doesn't exclude a septic arthritis. They have similar onset, often over several days of symptoms. Fever is one of the more discriminatory features in that a child with a very high fever is more likely to have a septic arthritis than a transient synovitis. You shouldn't really be having high-grade fevers with transient synovitis. A child with septic arthritis often looks systemically unwell, but not always at the start of their illness, whereas the child with transient synovitis should not be systemically unwell. Septic arthritis may be more severe in terms of the manifestation of the symptoms, particularly the effects on gait. So once it's established, a child will often not be weight-bearing, whereas with transient synovitis, they may be limping and not fully weight-bearing, but they often bear some on that limb. And on examination, you may find that the range of movements that's tolerated is very, very limited in septic arthritis, whereas it may be greater in a transient synovitis. But none of these features are sufficiently sensitive and specific to be really certain. And so investigations are often used, and there are many decision rules that have been proposed based on the results of investigations and a combination with clinical features. And I've just put one here. I don't really want you to pay too much attention to any of the values on this slide, but I would like you to just look at the sort of things that are in it, which are typical. So temperature, refusal to weight bear, C-reactive protein level. This is an American study where they report it in milligrams per deciliter, so multiply by 10 to get to the units that we frequently use. White cell count and ESR. And if you have 5 of these features, then the risk of having musculoskeletal infection becomes quite high. But if you only have a combination of 2 or 3 of them, it's relatively low. But what level are we prepared to tolerate in order to say this child needs to have a hip aspirate or similar intervention, which is the gold standard for diagnosis? And you can see from the ROC curve here that this is very far from a perfect test. So it's important to realize there is no perfect decision rule at all, but you do need to intervene early if you want to save a joint. And so I think in these cases, it's always worth seeking a senior review and other opinions and reevaluating a patient regularly. And even if you think they're low risk for septic arthritis, remember, they could be very early in the process. So having regular reevaluation of the patient with very rigorous safety netting is very important, even if you decide you're going to send them home because you're pretty certain it's a transient sinusitis. I'm going to take all the questions together at the end, so I'm just going to move on to the next case. This is a 16-month-old boy, previously healthy, who's been limping for 2 weeks. And he has had low-grade fevers during this time, not measured by his parents, but they said he's felt hot every day or so. He's got a swollen left knee. His CRP is 65, white cell count 11, neutrophil 7.4, and on ultrasound he had an effusion. So this was, because it was quite a large effusion, it was aspirated and turbid fluid was obtained, which had lots of white cells but no organisms seen. And at the moment, a culture is awaited. He was started on IV flucloxacillin, as was the protocol at the hospital where he presented. And at 48 hours, there was no growth in the cultures from the hip. He had not had antibiotics prior to the aspirate being taken. Symptoms persisted, although the knee was less swollen after 48 hours of antibiotics, and he's now afebrile. So you're left with a child without a clear diagnosis here, and I'd like to know what you would do next. So please, can you give me your votes? Okay, so I think typically we're having about 11 or 12 people responding to these. I'm assuming the others aren't able to respond. Oh, 13 this time, fantastic, okay. So we're going to close this poll in 5, 4, 3, 2, 1, and I'll show you the results. So I hope you can see those, and far and away the most popular option was an MRI, and then the next option, speak to microbiology. And I think those would be my top 2 answers here. I probably would speak to microbiology first and then do the MRI. But I'll give you the next part of this patient's history in a second. Okay, so he did have an MRI and we did speak to microbiology. And the MRI showed, as you can see here, very bright signal. This is with gadolinium contrast, very bright signal in the joint, in the bone, and in the muscle. And the speaking to microbiology was to ask them if they would do some molecular testing and some extended cultures of the joint fluid. And indeed, on extended culture, an organism called Kingella kingi grew in the joint fluid culture. And this child overall received 6 weeks of treatment in the end with ceftriaxone and ciprofloxacin, and that was because of having both septic arthritis and osteomyelitis. So we'll just do a little bit of revision of acute osteomyelitis and the organisms that cause it. So it's much more common than necrotizing fasciitis. The incidence is about 8 per 100,000 per year. The highest incidence is in under 1-year-olds, and about 50% of cases occur in under 5-year-olds. This is of all children. Most cases that we see are hematogenous. That means that the bacteria have reached the bone and indeed joint for septic arthritis via the bloodstream rather than through a penetrating injury or something bringing it in externally. Boys are typically more affected than girls. It's most often unifocal, so one site, but you can see multifocal, and that tends to be more common in neonates. And you can see concurrent septic arthritis in up to 1/3 of cases. The most common organisms are Staphylococcus aureus, Streptococcus pyogenes, that's your group A strep, and Strep pneumoniae, although for us we see very little Strep pneumoniae bone and joint infections now because we have vaccination that has massively reduced the burden of pneumococcal disease. And you can see the most common sites on this diagram. So the redder the bone, the more often the infections are there. So you can see the lower limb predominates. And if you want to read one paper on osteomyelitis, I would recommend this review referenced here from the New England Journal of Medicine. So just to put it another way, this table has quite a lot of information, but you're going to have access to these slides, and this just contrasts between neonates, young children, and older children in terms of the sites and organisms. So in the neonates, osteomyelitis is more often multifocal and involves the long bones. Septic arthritis most often involves the hip and the shoulder, which we don't see very often in other age groups. And the most common organisms here include group B strep, but also Staph aureus, and then a whole bunch of other organisms, including gram-negatives and fungi, which are predominantly seen in those receiving neonatal intensive care who have bacteremias or fungemias as a consequence of their neonatal intensive care. And the presentation can be very difficult in neonates, so it may be very non-specific. You may have a pseudoparalysis, but often it's picked up a bit later. In under 5-year-olds, it's usually the lower limb, usually unifocal, and most commonly it's Staph aureus. But Kingella kingi is a significant cause in this age group, and I'll tell you a little bit more about that organism in a moment. And it manifests with refusal to weight bear, limp, fever, and often localizing signs. And then over 5 years, femur, tibia, and humerus are the most common. It's mostly unifocal, and Staph aureus is far and away the most common organism, with others representing a very small proportion. And usually you have quite clear localizing features. Kingella kingi, which this child had, is a cause of osteoarticular disease, so that's bone and joint disease, almost exclusively in children under 5 years of age. It's an anaerobic gram-negative rod. It's difficult to culture, and so often we need to have extended cultures. People have reported that the ability to culture it can be improved by inoculating joint fluid into blood culture bottles. And now we would often detect it by doing a direct PCR for Kingella on the joint fluid. The symptoms have been reported to be less inflammatory than with Staph aureus, and so you may see a lower CRP than you're expecting. And typically it's susceptible to the same sort of treatment that we might use for treating Staph aureus osteomyelitis. Okay, So we're going to move on to another case. This is the penultimate one, I think, and this is a 13-year-old girl, previously well, who plays martial arts, and she has 5 days of fever, 2 days of right hip pain and flu-like symptoms. And she's been admitted to her local hospital and then discharged the next morning because she was afebrile overnight. They didn't do any further investigations. They were kind of just observing. But she returned the next day with fever and more pain, and she did have some bloods done and was found to have a CRP of 210, white cell count of 4, neutrophils of 0.9. And the hip pain was severe, and so she went on to have a right hip effusion diagnosed and washed out in theatre. It was purulent fluid with gram-positive cocci in clusters. And according to the local protocol, she was started on flucloxacillin and benzyl penicillin. But 2 days later, she was still febrile. She started to develop respiratory distress and then fluid refractory hypotension and required transfer to pediatric intensive care. So she clearly has got much sicker. So I want to ask you what you think we should do next in this case. And can you give me your vote, bearing in mind there isn't necessarily a single correct answer here. Okay, and I'm going to close the poll in 5, 4, 3, 2, 1. Okay, so we have a fairly even spread across all of the answers here. So I think I might have gone for something else, but my something else being all of the above. So I think every answer here is valid in this case. So what did actually happen was that antibiotics were changed to clindamycin and rifampicin. Intravenous immunoglobulin was given. There was some more imaging. The child was very sick, so too sick to transfer for an MRI scan, but high resolution ultrasound was done on the intensive care unit, and this showed extensive periosteal elevation over the right femur. That's indicating that there is not just the septic arthritis that was diagnosed initially, but periosteal elevation indicates that the bone is involved, so there is osteomyelitis. Surgical drainage was performed from the femur as well, and large amounts of thick pus were pulled out of the whole femur, essentially. And ultimately, this ended up being repeated 7 times during the course of this child's hospital stay. And the additional discussion with microbiology was to ask them to test this organism, which on the initial gram stain looked like Staphylococcus aureus, and to see whether these gram-positive cocci in clusters were both methicillin sensitive, MSSA, but also whether they were expressing a particular toxin called Panton-Valentine leukocidin. So this is a bit of imaging from this case. You can see the hip joints, which is severely damaged, the neck of femur severely damaged, and even down into the femur here, you can see these scalloped areas, which I'm tracing with my cursor, which are fenestrations which were made by the orthopedic surgeons so that they could remove pus from the femur. They couldn't simply drill it in this case. The pus was so thick they needed to make actual windows in order to scoop out the pus from the femur. And the other figure shows ultrasound of the femoral veins, and you can see the artery marked, the femoral vessels, the artery marked with an A, and the femoral vein marked with a V, which contains thrombosis. So adjacent to the site of infection, there was a deep vein thrombosis. So the key learning point here is that this child had a particularly virulent staphylococcus causing their illness, and it was one expressing a toxin called Panton-Valentine leukocidin. And it is important to know about this and recognize the features of it, because it does change your management. So this is a toxin that kills leukocytes, and particularly neutrophils. And toxin production is actually stimulated by some antibiotics, including flucloxacillin and other beta-lactams, but it can be suppressed by other antibiotics which inhibit protein synthesis, like clindamycin and rifampicin. It's associated with more severe disease in staphylococcal bone and joint infections, and it's very frequently associated with venous thrombosis because it produces a very potent inflammatory response in the area around the infection. The presentation is more commonly with multifocal disease, or if it's local, it's often very extensive osteoarticular infection, accompanied by severe sepsis, and sometimes another manifestation of it is necrotizing pneumonia in young people. There may be a travel history. There may be a history of recurrent abscesses in the family, because when it causes skin infections, it tends to cause abscesses. And the lab results typically show very high inflammatory response, sometimes leukopenia and neutropenia. And the recommended management when you suspect this is to at least add an antibiotic that is known to reduce toxin production by this organism, such as clindamycin, or occasionally linezolid if it's a methicillin resistant Staphylococcus aureus. If severe sepsis is present, then IVIG is recommended. Aggressive orthopedic intervention is probably justified, at least initially, and ultimately the child and the family will need decolonization to eliminate the risk of recurrent infections. There are some Health Protection Agency or PaeCH guidelines on this type of infection. Okay, so the final case, I'm going to move on quickly because I can see time is pressing. So this is a 14-year-old boy who presented to our department with painful shoulders and lower limbs, fever and flu-like symptoms. He had also had a transient urticarial rash over the last 24 hours. He'd come back 2 weeks ago from a fairly long family trip to visit extended family in Cairo, Egypt. He returned, after coming back from Egypt, he had then done a school hiking expedition, which had ended 2 days ago. And then all day yesterday, he had been playing football, which was quite unusual for him, because usually he was a bit of a couch potato. So I wonder what you think is the most likely diagnosis here based on that history. Can you give me your votes, please? Okay, and I'm going to close this poll in 5, 4, 3, 2, 1. Okay, so the top differential was viral myositis, but some thought exercise induced myalgia because he'd been doing a lot more exercise than usual. Dermatomyositis was up there. Trichonellosis, I wonder if anyone knew what that is, but that is a parasitic worm infection where the worms often end up in the muscle and can cause myalgia and pain. And something else, well, unfortunately, I can't ask you what something else might be at the moment. So let's give you a little bit more information about this case. So on examination, he was found to have a 2 by 2 centimeter sloughy scab over his lower lumbar spine, which he said had been sustained from a sort of carpet burn, friction burn type injury a couple of weeks ago while he was in Egypt. He had some swelling over his right shoulder, which was tender but not hot, and there was definitely restricted movement there. And he had pain on palpation of both his thighs and particularly his buttocks, and limited external rotation at both hips. His blood test showed an elevated white cell count with neutrophilia, a CRP of 246 and a creatine kinase of 684. He underwent some imaging. He had ultrasounds and x-rays of the affected areas, and essentially all of those appeared normal. So I'd like you to tell me if your differential diagnosis has changed based on those results. Okay, and we're going to close the poll in 5, 4, 3, 2, 1. Okay, so the top vote was actually now for multifocal septic arthritis / osteomyelitis, which I assume has been partly based on those high inflammatory markers, although I think the ultrasound scans provide little evidence that there is septic arthritis here. So it would have to be really osteomyelitis. Although actually the radiologists did tell us that it's very hard to detect effusions in the shoulder joint on ultrasound. And we still have a few votes for dermatomyositis, viral myositis, and trichonellosis. So in fact, what this child had was something else, which is multifocal pyomyositis. So I'm showing you MRI scans with gadolinium enhancement here. And in the left-hand image, you can see this area with bright signal around the dark signal, which is an abscess in muscle around the shoulder. And then on the right-hand scan, you can see a plane which captures gluteal muscles on both sides. And we have actually abscesses in the gluteal muscles and in some of the other muscles. And remember, I work in ID. I'm not an anatomist, so I can't remember all of their names. And also over here, very extensive abscess in the gluteal muscles on the right-hand side as well. So in this case, there were multiple lesions in the muscle suggestive of bacterial abscesses, but the joints and bone were uninvolved. So he was initially treated with ceftriaxone and clindamycin, as is our protocol. But we swabbed the lesion on his back, and this grew MRSA, which fortunately was sensitive to clindamycin, so he had been receiving some effective treatment, but the ceftriaxone would not be working. So it was changed to teicoplanin and clindamycin, and then he received actually a 6-week treatment course in total because of the size and number of these lesions. And what we assume happened was that the lesion on his back had become infected with MRSA, and then perhaps while he was doing the hiking expedition or the football, there had been a transient bacteremia from this, which had settled in the muscles, which he was not so accustomed to using, so they had been strained to some extent during the physical exertion, and provided a nice environment for the bacteria to settle in. So hematogenous spread to those locations. He had no evidence of immune deficiency on quite extensive testing. So the learning point from this is, first of all, about imaging modalities. So it's important to say plain X-rays were not likely to be very helpful here. They take about 10 days before they become abnormal in osteomyelitis, and they won't pick up muscle infection, and they're not often very useful for joint infection unless it's really, really gross. Ultrasound can be very useful for detecting joint effusion. You can also see muscle abscesses, but deep ones can be very difficult to pick up. And a skilled radiologist can pick up periosteal elevation, which may be a very important clue in a very sick patient where you're not sure where the focus is. It's readily available, but it's very operator dependent. MRI is usually the best to assess all of the soft tissue and musculoskeletal tissues, and also the extent of disease, and often guides our duration of treatment. And bone scan we very rarely use. People think of using it to look for clinically occult sites of infection, but actually if you did a really good history and examination already, it rarely adds very much. Don't forget that pyomyositis can occur in isolation. It doesn't have to coexist with bone and joint involvement, and so the negative ultrasounds and X-ray don't rule it out. And another important point from this case is, don't forget that travellers may bring resistant bacteria with them. So we don't see very, very much community-acquired MRSA in the UK, but in other countries it's much more common, and sometimes you have to think about modifying your empirical treatment based on the sensitivities of where of organisms where the person has come from, and you should always discuss that with ID and microbiology. So I'm about to end, and we'll have a few minutes for questions, but just to summarize, we've revised some important presentations of soft tissue and musculoskeletal infections in children, including necrotizing fasciitis, septic arthritis, osteomyelitis, and pyomyositis. We've discussed some factors influencing initial management, how to interpret some of the clinical findings and blood results, choice of imaging modalities, choice of initial antimicrobial agent, and some adjunctive treatments like immunoglobulin and additional antibiotics to suppress toxin production. And we've identified some presentations that should not be missed. So the septic arthritis versus transient synovitis, the culture negative Kingella infection, the PVL Staph aureus with its fairly typical features, invasive group A strep, and pyomyositis without bone and joint infection. So I'm happy to take questions now and discuss any of these issues. All right. Ingrid, I see you put a question much earlier on, which I did not see as we were going through. So that was case 2, which was the child with the septic arthritis. So in that case, I can't remember exactly, but there's very much a trend to make fairly early switch from IV to oral now if a child will tolerate oral antibiotics for treatment of septic arthritis. And it may be as short as a few days of IV treatment is adequate. Andy says, thank you for the talk. Who would you send for immunology for follow-up after a really severe soft tissue infection? So Andy, we tend to do basic immunology investigations ourselves in any child who's had a very, very severe infection. And that would often include looking for HIV status, looking at immunoglobulins, looking at lymphocyte subsets, and depending on the organism, sometimes looking for spleen, looking for complement function. I think there's an argument in any child over 2 who has had an invasive pneumococcal infection these days, when pneumococcal vaccine is so widespread and we see so little of it. If they have a severe pneumococcal musculoskeletal infection, I think those children warrant more thorough workup. And anyone who has an unusual organism or a persistent infection that's very difficult to treat warrants a workup as well. Many of the severe infections that we see are due to particularly virulent organisms. I think the PVL staph, we had a problem with particularly a few years ago, but we see less of it now. And that often is the explanation for why the infection is severe rather than host factors. Any other questions? Thanks, Elizabeth. Okay, then I think we're basically done. So if you want to go, thank you very much indeed for coming, and I hope you enjoyed it.
Thank you very much.
Next week's session, I'm just trying to, Nicola, do you?
I do, yes. So we're back next week with Claire Hogg, and she's going to talk to us about PCD.
Brilliant.
And please pass the word on. These talks are going to be uploaded. If you haven't got the link, Nicola has it. Please pass it on for those who haven't been able to attend in real time. And also, please, any suggestions? We've got a program to the end of this term. We're taking August off. What do we want to do in September going forward? Any suggestions, particularly from trainees? These are aimed at you. Please tell us what we want to hear what you want, rather than an old fart like me imagining what you want. So please tell us.
Great. Thanks, everyone.